Good morning, everyone, and welcome to the DiaBeat webinar, part of our Rack Diabetes Challenge 2024. This is session number 8, and this week we are discussing diabetic foot. To help us understand this better, I am joined by and have the privilege to introduce our speaker, Dr. Shalabh Mohan. Dr. Shalabh Mohan is an MS in general surgery. His specialty is general and minimal access surgery, and he practices at Rack Hospital. Dr. Shalabh is a skilled surgeon. He earned his MBBS in 1994 and MS in general surgery in 2001 from prestigious medical colleges in New Delhi, India. With extensive expertise for 28 years in laparoscopic, general, and obesity surgeries, he has garnered several fellowships from prominent medical associations. Prior to his tenure at Rack Hospital, he worked at renowned hospitals like Max Hospital and Primus Hospital in India. He has actively participated in various medical courses, conferences, and workshops across India, Germany, the USA, Taiwan, Tokyo, and Singapore. His unwavering commitment is to provide personalized medical care to enhance the well-being of his patients. Dr. Mohan, over to you, sir.
Doc, you are muted. And you have to share your presentation also.
Yes. Can you hear me now?
Yes, Doc.
Yes, sir.
Hi, good morning all. Thank you for that very nice introduction. And today I'll be talking about diabetic foot, all matters surgical related to that. Also about why it happens, to try and explain to patients the process and the reasons why we treat it as a cause of concern, right? And I'll just start right away with my presentation. Okay. I hope it's visible.
Yes, sir.
Yes. So, the diabetic foot, why is it so important? I'll be discussing this basically what it is exactly, the anatomy of the foot and how it's relevant to the disease, what are the causes, how do we assess it, how do we test for various parameters involved in the disease, and how do we treat it, right? So basically, what exactly is a diabetic foot? It's a condition where there's in a patient who is diabetic, he has an ulcer in the foot or a wound, and that leads to various complications. Now, the thing to understand is it's a significant number of patients are affected by this disease, but less than half of patients with diabetes are actually aware that this is a problem. 15% of patients will eventually have some form of diabetic foot during their lifetime. And the primary cause is uncontrolled diabetes, which leads to breakdown of the various tissues of the foot. And if it is left untreated, it can cause major problems. The worst, obviously, being an amputation of the foot. Prior to that, there will be inflammation, infection involving the soft tissues and the bones. And that infection can even spread to the rest of the body and lead to sepsis. Now, the various risk factors for diabetic foot, right? The most important and the most prominent being obviously uncontrolled blood sugar, lifestyle problems, excessive alcohol consumption, coexisting diseases like cardiovascular diseases and obesity, smoking, kidney disease. The best way to remember how to watch out for the warning signs of a diabetic foot, the 6 Ps. There's pain, there's pallor, the foot might appear pale. There's pulselessness. The distal pulses appear to be getting weak, or they disappear altogether. There's paresthesia, which is an abnormal sensation. So patients will be complaining of tingling, numbness, aching in the muscles. There might be paralysis, so the movement of the foot gets compromised. And poikilothermia, or basically a cold foot, because the temperature regulation by the small blood vessels of the foot gets damaged. Other symptoms: excessive swelling, there may be bleeding, irritation in the skin with redness, ulcerations, and a foul odor, because the glands of the skin, they stop functioning properly. A very brief look at the anatomy of the foot. I'll not go into great detail. It's basically to emphasize the fact that this is a very, very complex part of our body. It is comprised of multiple small bones and multiple layers of muscles and fibrous tissue, all of which makes a very complex mechanism which allows us to support our weight and to walk with which, and apart from weight bearing, the function of the foot is also to absorb impact. Right, so these are the various layers of the muscles of the foot. I'm going to quickly go through them. Idea here is to simply emphasize it's a complex piece of anatomy, and diseases in this are not so very easy to treat. A very prominent part of our foot function is the arches of the foot. It is these arches which maintain shape and which provide distribution of weight as well as absorption of the shock whenever we are running or jumping. And these arches, for us to have a healthy foot and a healthy active lifestyle, these arches need to be maintained. And this is what gets compromised in a diabetic foot. So this gives you a brief overview of what these arches do. So basically, these arches are maintained by the tension of the ligaments, and they provide like a shock absorption for the foot when we are walking or when we are at play or when we are running. The nerves, multiple small nerves run through these muscles and tissues. And apart from the nerves which supply the muscles, there are as many as 7 nerves which are involved in the cutaneous distribution of the foot. How does this all happen? How does a diabetic foot start? It's a multifactorial thing, multiple factors at play. There's a neuropathy, vasculopathy, immune dysfunction, infection. Basically, the nerves, the blood vessels, your immunity, and infection by entering the soft tissues, all of this plays a role. And all of these are obviously exaggerated by hyperglycemia or uncontrolled blood sugar. So this gives a overview of the interplay of all these factors. There's relative ischemia because blood supply to the foot is reduced. That's the vasculopathy. A motor neuropathy, that means muscle and ligament weakness, which leads to deformities and abnormal pressure points on the sole of the foot. There's a sensory neuropathy, and this is very important because there's a loss of protective sensation. So imagine whenever we step on a hot surface or a sharp object, immediately we withdraw because we have a sensation of pain. If that pain sensation is compromised, we will not be aware of the damage that we are sustaining. We will not be aware of the injury, and that will lead to actually more injury. Then there's an autonomic neuropathy. So the regulation of the blood flow through the foot, the temperature of the feet is by fine blood vessels and capillaries, which are in turn regulated by the autonomic nervous system. And finally, there's an immune dysfunction, which leads to increased predisposition to infections. This is basically a more detailed chart of how the various factors are into play during the development of the diabetic foot. The peripheral neuropathy, that's the main issue. And this is caused by the nerve death of the small and finer blood nerves within the foot. There are metabolic changes which are happening in the body because of uncontrolled diabetes and vascular compromise. I'll skip through this. This is probably more interest to medical colleagues. For the normal layperson, this basic understanding here is increased glucose in the body leads to these increased neuropathy through various mechanisms, right? The small sensory fibers, when they are damaged, you'll no longer be able to feel pain. You'll no longer be able to feel fluctuations in temperature, something which is a surface which is too hot or too cold. The larger sensory nerve fibers, you will not be able to feel sensations like light touch or proprioception. Proprioception is our sense of awareness or what exactly is the position of the foot. So this is what happens. With all these factors, we tend to develop toe deformities, right? Because of the shortening of the ligamentous structures, because of the abnormal function of the muscles. So these abnormalities, these toe deformities, eventually will lead to abnormal pressure points. So patients will typically suffer from shoe bites or ulcerations at the abnormal pressure points. And that's where the whole story starts. That's where the infection gets introduced into the foot. As you can see, there will be deformity in the joints, deviated toes. There's a loss of the arches as well. So the areas of the foot which are not supposed to have pressure on them, those areas get exposed to abnormal pressure. And that's where the skin breaks down and leads to ulcers. There's limited mobility of the joints. In diabetes, it can affect the hands as well as the feet. But in feet, when there's a loss of foot sensation or proprioception, it's going to lead to increased risk of injury. It's going to lead to an abnormal sense of balance. If you can't feel your feet properly, you lose your sense of balance. You're more likely to have falls. This is how it starts from in the beginning. As you can see, the first figure, the skin appears to be dry. There's cracking. There's areas of thickening of the skin, right? And basically, most of this happens because of an autonomic dysfunction. The foot, the skin of the foot, has multiple glands which provide moisture to the skin, keep it healthy. Those glands get affected. Temperature regulation gets affected, and the skin starts becoming thicker. It is more prone to cracking and injury. Peripheral vascular disease, the next part of next component in the diabetic foot, apart after neuropathy, is a vasculopathy. Typically in diabetes, your patients are more prone to atherosclerosis, which is a deposition of a plaque in the larger blood vessels. That will also contribute to poor blood flow. About 20 to 40% of diabetic patients will have a peripheral vascular disease. Now, the second point is important. With just a 1% increase in your HbA1c leads to a significant risk in the development of peripheral vascular disease. All of us, when we treat diabetes, we tell our patients that HbA1c is important. You need to monitor it. That's how we know whether your blood sugar is controlled or not in the long term. But we usually fail to warn our patients about the implications of high HbA1c. What are the problems that it can cause? And why are we so concerned about controlling it and bringing it down to acceptable levels? There's a slight difference in the kind of atherosclerosis that non-diabetic patients may have as compared to diabetes. This is important because when we come and discuss the treatment options, if a patient has atherosclerosis and who's not diabetic, he's going to have primarily large vessel disease. A diabetic patient will have the disease in the smaller vessels. It is actually easier to treat the larger vessels than the smaller ones. The point I'm trying to make here with this slide, it's a little more difficult to treat the vasculopathy in a diabetic. The other part is infections. Your immune system is compromised. If you are diabetic, your blood sugar is poor, then all the factors which play an important role in immunity, your white blood cells and their function, that gets deranged. The chemical interplay between these cells, which help in regulating immunity, that also gets damaged. When we give any patient an antibiotic because we see any soft tissue infection, in diabetics, especially infection of the foot, the role of the antibiotic is less because even if you consume adequate antibiotics, the antibiotic doesn't actually reach the tissue where it is supposed to act because of poor blood supply. Typically, the most common infection in acute stages is staph, which is normally living in our skin. We have skin thickening, skin breakdown, and that leads to the entry of the normal skin bacteria. Patients who have chronic infection usually develop infections caused by different microorganisms, which are now more resistant to antibiotics because we've been treating them with multiple sessions of antibiotics. Eventually, the worst component of infection in a diabetic foot is the involvement of the bone. Treating bone infections is difficult, and it is usually culminates in an amputation. The commonest site of infection, usually the site where the skin break happens most frequently, is going to be the forefoot. The commonest bones affected will be the smaller bones in the forefoot and the heel. These are the points of maximum impact. There are various studies that can be done to assess involvement of bone. Usually, a plain X-ray is the best way to start off. Bone biopsies would obviously be something which confirms the diagnosis, but we rarely do it because it is an uncomfortable procedure to get done. Diabetic foot ulcer, one of the most common complications in diabetic patients, and probably the least discussed. Whenever the patient with diabetes comes to the hospital, the discussion with the patient usually is about controlling his cardiovascular disease or his cholesterol or taking care of the eyes. The foot usually is rarely, if ever, discussed. Treatment in diabetic ulcers, very difficult, it's prolonged, expensive, long-term medication is required, frequent hospitalizations, and eventually culminating in amputations. It's easier to prevent a diabetic foot than to treat one. Various preventive measures that we can adopt as diabetics to make sure that our feet stay healthy for a long time. Lifestyle modification. Basically, we are focusing on primarily on controlling our blood sugar, which is lifestyle modification, a healthy diet, healthy exercise, controlling our blood pressure, controlling our cholesterol levels and sugar. Smoking, a very, very important component in diabetic foot. If you are a smoker and you are diabetic, the risk of diabetic foot complications is extremely high. And the damage that happens to the foot, the neuropathy, the vasculopathy is accelerated if you're a smoker. This is a small demonstration of how to take care of the feet when you're diabetic. It's important to follow a regular protocol every day. We should get into the habit of it. It takes barely 2 to 3 minutes to do it. It could be part of your daily routine when you take a bath. And it should be something which should be emphasized to all our patients. Wash and keep your feet clean. Warm water. It is important after washing to dry your feet, especially between the toes, because that's the area where moisture collects and leads to skin maceration, and that's a point of entry for bacteria. Dry your feet, but don't forget to moisturize, because moisturized skin is less likely to develop cracks and ulcerations. Check your feet for blisters or for any cuts or sores, especially if you've been wearing shoes for a long period during that particular day. Taking care of your toenails. It's a simple task, but I see it so often. A patient who is diabetic comes in with a small problem, probably an ingrowing nail, and before you know it, it becomes a major issue, which lasts for weeks to months, and we're struggling to deal with the infection in the foot. Toenails are to be trimmed. It is not important to cut off the entire part of the dead nail. Just trim it so that it doesn't project beyond the toe. Always cut your nails square. Don't round them off. If you can't see the edges of a nail, you trim too much. All of this leads to small injuries and the tendency towards ingrowing nails. That's a focal point where a diabetic foot ulcer can start. Rest of it would be obviously maintain good hygiene, wear clean socks, be sure to change your socks every day. Keep your feet warm and dry. Shoes are a very important component of care for diabetic foot. Shoes have to be well fitted, not too loose, not too tight. There should be no abnormal pressure points in the soles, which will cause damage to the skin. They should be comfortable. There should be cushioning in the sole, which absorbs impact because you've lost your arches, right? Never walk barefoot. It's not okay to walk barefoot even in the house. And always get into the habit of examining your shoes and your feet at the end of the day when you take them off. Is there any, because you can't feel, there's a loss of sensation if you have a neuropathy. You will not be able to feel if there's anything, if there's a shoe bite or there's some portion of the shoe which is pushing into the tissues and might cause blisters or ulcerations. Inspect your shoe every day, or at least as often as you can. Make sure there are no points in the sole which seem to be hard and with protrusions which can cause injuries. Inspect your feet. Do your feet, does the skin appear healthy? Are there any areas of inflammation at the end of the day? That would suggest that there's an abnormal pressure point out there. Take care of your feet. Clean your feet with soft brushes. Use a mirror to inspect those areas that you can't see clearly. Don't try surgery at home. That's one little thing I will always request my patients. Don't try to cut into an ingrowing nail. Don't use any metal devices to dig under the nail bed to clean out anything. These lead to small injuries, which eventually lead to introduction of infection. So when a patient comes in and we suspect that he's having a problem with diabetes and we need to examine his feet, a detailed history and examination is essential to catch the problems early. What is the daily activity? What kind of shoes does he wear? Is there any exposure to chemicals? Is the foot having any areas where the skin is becoming thick that suggests areas of friction? Are there any deformities? A deformed joint would lead to, again, an abnormal pressure point, which will again cause ulceration. Any previous foot surgery? Does the patient complain of any symptoms which would suggest a neuropathy or ischemia? If there's an ulcer, where is it located? How long has it been there? What was the triggering event which caused it to happen? Is there any active infection which is visible? What method of wound care has the patient taken? Is the patient doing anything to take the pressure off those points? Is the patient compliant? If there's an ulcer, patients need to clean and dress the wounds daily. Sometimes they don't, and then that makes it worse. So when we examine, we look at the pulses. In a diabetic patient, oftentimes the pulses are faint or they're absent because of the vasculopathy. The skin color might be dark because of poor drainage of the venous blood. It might be red and inflamed because of irritation. It might show edema or swelling. How does the skin appear? Is it normal, smooth and soft, or is there any evidence of dryness? Are the nails thick and are they cracking? A very significant sign is the loss of hair in the feet. That suggests that the vascular compromise is now becoming significant. So this is how we assess vascular compromise, and we do a vascular assessment if the patient has significant ischemia and may require surgery. A neurological examination to assess the various aspects of sensory loss, vibration test with a tuning fork, light pressure using a small wick of cotton, or light touch, 2-point discrimination. Is a patient able to differentiate between the 2 points of touch, right? Is he able to sense minor injuries like a pinprick? Is he able to differentiate between very hot or very cold surfaces? The next thing to look for is any visible deformities of the toes or the feet. And is there any resulting abnormality in the walk or the gait of the patient? When in diabetic foot, when the joints get destroyed because of neuropathy and deformity, you can see the visible deformities. There's going to be hot, swollen red extremities. There's a differential diagnosis here. A lot of people or doctors even would assume that the patient might have gout or a fracture or just a soft tissue infection. We need to keep in mind that this is a diabetic foot and requires specialized treatment. People who lose their arches and who have flat feet or deformities sometimes need these kind of special shoes to distribute the pressure away from the foot. Right, I already touched on this, the appearance of skin, whether it's dry, whether it's calloused, with small cuts or fissures. How do the nails appear, whether there's a loss of hair. It doesn't just stop with examining the patient. You need to see what kind of shoes he's wearing. Are they well fitted? Not too loose, not too tight. Is there any crowding of the toes? Is the lining comfortable and padded? Are there any foreign bodies inside the shoe? Routine blood work for diabetes and for any infection, it stays the same. We get blood counts, we check the HbA1c and the sugar, we get cultures done from the wound. Plain x-rays, like I mentioned, sometimes more advanced radiology may be required if you're planning an intervention, a CT or an MRI. How do you classify a diabetic foot? It's important for us to be able to assess the severity of the disease and to educate the patient on how to take care of himself. So the most common classification used is what is known as the Wagner's classification, starting from 0 to 5. Basically, is where the skin is intact, but we can see impending changes which could progress to an obvious ulcer. Grade 1 is a superficial ulcer. Grade 2 is a deeper ulcer where the muscles or the ligaments or the bone is now exposed. Grade 3, where the infection has spread into the bone. 4 is a localized gangrene. Gangrene would mean involving all the components, the soft tissues, the muscles, and the bone. If it's localized to the toes, it's grade 4. If it is more extensive, it's grade 5. These images basically give an explanation of the classification that we use to plan treatment for a patient. It's a simple method for classification. Obviously, it's not perfect, but it usually serves well for day-to-day management of patients who come into the OPD. There's another set of images to basically drive home the point that this can lead to major problems. This is the other classification that is used. Again, this is more for clinical purposes rather than for patient education. I'll skip through this. Treatment, how do we treat this? It has to be a multidisciplinary approach. The physician, the surgeon, the podiatrist, all of us are involved in the care and management of the diabetic foot, right? Patient education is an essential part of treatment. They need to know what's happening, why it's happening, and what can be done for it. And obviously, they have to be very, very aware of managing the blood sugar. If a patient has an ulcer, the site needs to be recorded along with the depth. We need to track the ulcer during the various phases of its treatment to make sure that progress is happening. It takes a very long time for these ulcers to heal, mainly because of compromised blood supply, because of abnormal pressure points, and the fact that we need to walk on our feet. Wound healing is always going to be delayed. There's also always a need for debridement of dead tissues. Treatment with Oral or intravenous antibiotics based on swabs is done. It's one important component of treatment is obviously shoe modification to prevent formation of any further ulcers and to relieve the pressure from the abnormal pressure points. To do that, we sometimes use casts or specialized orthotic shoes to redistribute the pressure. This is what is known as an offloading device, a cast and a specialized shoe, which basically allows for most of the weight to be centered on the upper part of the leg rather than on the feet. Wound dressings. Even the dressing is important. It's not a straightforward thing. You see a wound, you clean it, apply some antiseptic, and do a dressing. Depending on the kind of wound, whether it's dry or whether it's actively infected or there's a discharge, dressings have to be planned. The first step, obviously, for management of wound is debridement, whether we do it surgically or whether we do it with application of certain chemicals. Hydrogen peroxide is an example. Usol solution is an example, or certain enzyme-based ointments which would help digest the necrotic tissue. Then there are medicated dressings which are available. There's a small list of them. Basically, some common dressings look like this. They are soaked with antiseptics or antibiotics, and they have this tendency to absorb excess moisture and yet retain a moist environment to allow skin healing. These are specialized dressings that patients may require. These usually require a hospital setting for them. One is vacuum-assisted dressing, where the foot is placed in a closed space, in a plastic bag, if you will, and a vacuum is applied to that, removes the exudate, and it promotes rapid growth of granulation tissue and healing. One other component is hyperbaric oxygen therapy. There's a lot of divided opinion about whether it is actually useful or not in these settings, but it is an available option. This is what happens with vacuum dressings. We do a specialized dressing where we wrap the foot in an airtight dressing, and the environment within the foot is there is going to be a vacuum which is applied by a device. Patients usually have to stay bedridden, they cannot move around much, and it can be expensive. So let's emphasize on prevention more. Skin grafting is an option when there's a lot of extensive tissue loss, but skin grafting in these patients is difficult. This part of the body has compromised blood supply, and it has small muscles and bones. Again, not a very good bed for a graft to take. The most feared complication of a patient who has diabetes and an infected foot is amputation. Eventually, if all other methods fail and the foot is either dead, which means the tissues are completely unsalvageable, or deadly, if there's severe infection which is compromising sugar control and there's a risk of sepsis of the infection spreading elsewhere into the body, or if it's a dead loss, in which there is the tissues are there in the foot, but it is not a viable foot in terms of function. Those are the times when we need to do an amputation. It requires extensive counseling. It requires a lot of investigations to make sure that when the amputation is done, the remnant of the has adequate blood supply to heal adequately, right? Amputation could be at various levels, starting from the toe and moving up. Amputations and the mortality associated with it have a close correlation. A diabetic patient with an amputation has a high risk of morbidity and mortality. There are various studies which have suggested that following an amputation, patients do not live for very long. So we need to avoid getting to a stage where a major amputation is required as much as possible. There's another option for treatment, which is revascularization, basically improving the blood flow of the foot. In diabetics, this is a difficult option. Revascularization works best in patients who have large vessel disease, where we can divert the blood away from the obstruction and into the distal vessels. Now, in diabetes, it is the distal vessels themselves which are involved. So, revascularization is not a very useful procedure in those patients who have significant peripheral vasculopathy. So, I quickly go through these slides. Various options in endovascular management to open up the blood flow going into the lower limbs. We all know what angioplasty is for the heart. It's something very similar for the lower limbs. Now, this is the part that we need to take home with us. Counseling and education is important. Patients need to be aware that this is also an important area which needs attention. They need to be educated about the implications. They need to be educated about how to take preventive measures. Daily care of the foot should be an important ritual every day for every diabetic. It's not important whether it's early diabetes or late diabetes. A daily ritual where there's special attention paid to the foot, it takes less than 2 minutes, should be there. Inspect the foot daily for cuts or sores, any wounds. Do not walk barefoot. Wear well-fitting shoes. Be aware of whatever you apply to your skin. It could be, if it's alcohol-based and it is irritant, it might not be the best thing for a patient with diabetes. Don't try surgery at home. Don't cut corns and calluses by yourself. You might end up introducing infection and making things worse. Don't heat your feet. Now, with diabetes, you're more likely to feel cold, especially in countries where it's very cold and wintertime. We like to sit in front of a heater and warm our toes. That's okay for people with normal sensation, but if your sensation is abnormal, you might end up with burns or injuries, and that would be where a diabetic foot starts. At the end of the day, shake out your shoes. Look at your shoes. Look at your feet. No smoking. I'm emphasizing that again. That is an important and a correctable factor. Well, everything, when you're diabetic, you need to exercise. Exercise is important. But exercise in the right way, avoid high impact exercises which will further damage the arches of your foot. Swimming or cycling is a good option. Walking is a good option as long as it's not on a hard surface and you're not doing high impact walking, right? Periodic exams. Make it a routine to check yourself daily, and every few months you should go to the doctor who will examine your feet and make sure that everything is fine. And finally, of course, controlling diabetes, because that's where it all starts. Thank you.
Dr. Mohan, thank you so very much for that. Fortunately for me, I am not diabetic, but I was listening so intently as a wife, as a daughter-in-law, as a daughter and a friend, because within my circle, so many people have diabetes. And it's shocking because I've been going to the endocrinologist with my husband for 15 years now, and never once has anyone spoken to me about his feet. I mean, he has, but never once has anyone spoken to me about his feet. And thank you so much for addressing that. Doctors just, they give you a diagnosis, they tell you you should control your blood sugar, but they never really tell you about these consequences. You know, I never understood how neuropathy, I understand how it causes a foot ulcer, but I didn't understand how much it complicates the treatment, you know, antibiotics not getting there, not getting where they need to get to, and just never understood. My husband is very particular about his footwear. He's a doctor as well. And I always thought he's just fussy. Now I completely understand. So thank you so much also for just a lay person being able to to assess their feet, you know, the 6 P's. Thank you so much for that. That was so helpful. and just helping us to, usually it's the carer. I was watching this as a carer, of someone who has diabetes. And now I know what to look for, just thank you so very much. We have lots of questions coming in.
That's a little point. In fact, at home, because see, when you're diabetic, especially in the older age group, you have compromised vision as well. So this aspect of visually putting the feet in the shoes should, if possible, it should be someone at home who can take care of it if the patient himself cannot inspect.
Yes.
So inspection, very important on a regular basis.
Absolutely, absolutely. And moisturizing and cleaning and drying. And yes, having someone to look at it. And that foot mirror, the mirror that you showed us, thank you so much for describing that kit. It's so, I walked into this thinking, what am I going to learn today? And I have learned a lot. Thank you so much. Dr. Wilco, I could see some questions pouring in. So over to you.
Yeah. Thank you, Dr. Shalabh. Very nice presentation, simple words, and you have given a lot of things in the information. Like Ms. Zarina was also mentioning, doctors generally treat the patient. They do inform the patient what to do, what not to do. Patients are very reluctant. But your presentation, I can see immediately people are very afraid of getting into that situation. So first question, Zobia Adalat has asked, what is the chance of recurrence of the ulcer after surgery? People are very afraid. You made them really understandable that if you don't take care, you are going to suffer.
Okay.
So what is the chance of recurrence of an ulcer after a surgery?
Well, if you understand the reasons why it happened. So if you are not, we can do a surgery, we can do debridement, we can do any surgical technique, including revascularization. If you're not taking care of the cause, it's going to happen again. As it is going to be very difficult to treat, it'll take a very long time if and when it heals. Suppose it heals, but if the factors are still there, starting with sugar control and lifestyle, and obviously the rest of it, taking care of the pressure points and inspecting your feet and all of it, if those factors are not taken care of, it's going to happen again.
True. The second question, we have a Dhoni in participants. Dhoni has asked, can diabetes ulcer result in foot amputation? Because the way you were showing, if it is being neglected, it can lead to foot amputation. So is it true? He is very curious. You have already mentioned about it. So please elaborate again.
Amputations, minor or major. The reason for amputation, it's a simple mnemonic: dead, deadly, or a dead loss. If the tissue is dead, it has to go. If it's deadly, if it's a risk to the rest of the body, it has to go. So if it's badly infected and there's a risk of sepsis spreading, it has to go. And dead loss, you have a foot, but the arches are destroyed, the bones are destroyed. It's just tissue. And if you cannot walk on it, it's a dead loss. It might, and these are the difficult situations to explain to a patient and the family. It might, I have faced it myself when I had to tell a patient, you have a foot, you can see a few toes, you can see the heel, it's deformed, but you can't stand and walk on it. A diabetic who cannot walk and cannot exercise is going to make his diabetes worse. Sometimes it might be easier to do an amputation and offer a prosthetic, which will improve his lifestyle and his activity. So amputations, for any of these three reasons, dead, deadly, or dead loss, it will be required in diabetics. And once a major amputation is done, it significantly affects the lifestyle of the patient. Like I said, statistically, a significant number of patients who undergo major amputations are not likely to survive beyond a few years because a lot of things change. Sometimes repeated surgeries are required. So like I said, focus on the prevention because that's what works best.
Yeah, true. So there is very common questions we come across even when the diabetic challenge starts. People are coming for participating. So many of them ask these type of questions. So one of the questions Aniket has asked, is diabetic foot and gangrene same thing? Or is and also diabetic ulcer is fatal or it's
No. So actually, the term diabetic foot is also something which is I'm not very fond of it. It's basically a foot involvement in a patient of diabetes. It's the patient who's diabetic, not the foot, right? So ulcers are not necessarily fatal. It's all about the extent of the disease. You catch a disease early, it's easier to treat. If you catch it late, obviously it's going to make it so much more difficult. So gangrene is obviously the end stage of this disease, where the tissues are destroyed completely because of these problems: neuropathy, vasculopathy, loss of blood supply, and infection. So gangrene is the final stage in a diabetic foot, and the only option in gangrene is to remove the dead tissue, or basically an amputation.
Yeah. That was all questions asked, but I have one question, because you were mentioning about in the last foot care you were talking about, be gentle on your foot, don't heat your foot. I have
Exactly.
noticed I have experienced one of the patients in clinic. The patient was having tingling and formication sensation because the patient had a severe sciatica and the nerve were compressed. So patient was not having a proper sensation on the left foot.
That's right.
And somebody told to increase the circulation, maybe there is circulation problem, and to increase circulation, put your foot in the hot water, do hot water fermentation. And he tried. So he was not able to feel the heat. And there was a skin burning. And then once it became complicated, then he came to me. So even I was very surprised. So when you said, so I just recalled the same experience about the patient.
For a reason. Pain is important to us because pain is the way that we learn what to avoid, and we learn to avoid it in time before it causes more damage. Without pain, if you don't have pain, you can imagine the consequences. You are getting injured, but you don't realize that injury, and therefore you suffer a deeper injury. So pain is important. And in diabetics who don't have that sensation, it's important to be aware of this fact. They need to use their other senses to avoid these situations. I had a patient many years ago. He attended a funeral of a friend of his, and he walked on hot stone. You have to walk barefoot during those occasions, right? He walked barefoot, and he ended up with deep burns and ulcers on the soles of the feet. He himself was a diabetic. It took him many months to recover. So, and the only reason he had that was because he could not feel the heat, and he got severe burns, but had no pain. So pain is a reflex which is important to us to avoid these situations.
Yeah, true. Pain is an indicator which helps you to understand your body. That's a true sentence. Look, all the questions we have covered, you have wonderfully arranged everything, so I don't think so there will be confusion. But at the last, I would request you to give a 3-line pointers as a takeaway message for foot care. You have already mentioned, but only in 3 lines, simple lines.
3 lines: take care of your skin, take care of your foot, and always control your blood sugar. That is probably the best.
Yeah, perfect. Thank you very much, Dr. Shalabh, for a wonderful session. Over to you, Ms. Reena.
Thank you so much, Doctor. Thank you so much for this session. I've learned so much. Thank you very much to the RAC Hospital team. Thank you very much to the Arabian Wellness team. Thank you so much to our viewers. Please don't forget to join us on the 18th of October at 11 a.m. for our session by Dr. Savita Date Menon. And this will be on the psychological aspects of diabetes. Thank you very much to our viewers. Thank you to our team. Thank you again, Dr. Shalabh, and we will see you all next week.